Respiratory 202 Chapter 13. Airway Management. Intubation. Difficulties include burns or radiation, a small jaw, a limited range of motion, obesity and the structure of the mouth. Indications include pulmonary function such as a PaO2 less than 60 with more than 60% O2, a CO2 more than 50 to 60 or respiratory failure. To provide an airway if needed to bypass the epiglottis. To protect the airway if the Glasgow Coma scale is less than 8 or they are apneic. Or for hygiene if they have excessive secretions. Airway equipment needed. Monitors such as an ECG, a pulse ox, blood pressure and end-tidal CO2. Suction equipment such as a Yankauer and a catheter. Machines such as a source of O2, an ambulation bag and a vent. Airway equipment such as an ET tube, a stylet, a laryngoscope, the McGill forceps and LMS. IV equipment such as a patent IV, IO. And drugs such as RCS like propofol and ketamine. Endotracheal tube sizing. Pediatrics use an equation of age divided by 4 then plus 4. If it is cuffed you subtract 0.5. Neonatals are based off weight. Less than 1,000 grams equals a 2.5 uncuffed. 1,000 to 2,000 equals a 3.0 uncuffed. 2,000 to 3,000 equals a 3.5 uncuffed. 3,000 to 4,000 equals a 3.5 to 4.0 uncuffed or cuffed. Pediatric anatomy. The cricoid cartilage is the narrowest portion of the airway. The epiglottis is big and floppy compared to adults and they have a larger tongue. Below is an image showing the grading scale of an unobstructed airway. This is a side-by-side of a normal airway and one with edema. Blade sizing. The Miller is for infants with a size 0 to 3. It is placed over the epiglottis and then lifted. The Mac is for toddlers and adults with a size 1 to 4. It is inserted in the vallecula and then lifted. Intubating. The bed is raised to your xiphoid. A shoulder roll is placed under infants and pediatrics. Pre-oxygenating is a must. The blade is in the left hand and inserted on the right side of the mouth. You then sweep the tongue to the left. It is important to avoid the gums and teeth and then lift up. Visualize the cords and insert the tube. Checking placement. The depth should be 3 times the inner diameter of the tube. Check the breath sounds, chest rise, end-tidal CO2, tube condensation and the best way is an X-ray. Once confirmed secure the placement. It should be 2 centimeters above the carina or at T2 through T5 in kids. Other options if needed include LMS, nasotracheal intubation, cricothyroidotomy, and an emergency tracheotomy. Suctioning. Neonates get 60 to 80 millimeters of mercury of negative pressure. Pediatrics get 80 to 100 millimeters of mercury. A safe suction for neonates depends on the manufacturer. There is also bulb suctioning shown in the picture. Emergencies. Epiglottitis. The vaccine was created in 1988 and decreased the occurrence by over 96%. An unstable patient needs to go to the operating room immediately to be managed by the ENT. The patient's thumbprint is added to the X-ray. Laryngotracheal stenosis is subglottic narrowing and the severity varies. The patient will use one size smaller of an ET tube. Long segment stenosis equals more than 50% of the trachea affected. Here is an X-ray and image of epiglottitis. Here is an X-ray and image of laryngotracheal stenosis. A grade 1 is 0 to 50% obstructed. A grade 2 is 51 to 70% obstructed. A grade 3 is 71 to 99% obstructed. And a grade 4 is 100% obstructed.